There are four different stages to treatment and repair. The first one is hematoma formation, and a mass of clotted blood is called a hematoma. So the site is swollen, painful, and inflamed. The second stage is that there is kind of like this temporary cast. It's called a fibrocartilaginous callus that forms. So the capillaries grow into the hematoma. The dead cells are removed through phagocytes. Fibroblasts secrete collagen fibers to span the break. And there's kind of the beginning reconstruction of the bone. And this mass of repair tissue is called a fibrocartilaginous callus. The third step is a bony callus formation, and it happens about within 1 week. There's new trabeculae that appear in the fibrocartilaginous callus, and the callus is converted into bony or a hard callus of spongy bone. And this callus formation continues about 2 months until there is a firm union that is formed. And then finally, the last step is bone remodeling. It begins during the callus formation and continues for several months. The exterior material or excess material on the diaphysis, exterior and within the medullary cavity is removed. Now compact bone is laid down to reconstruct the shaft walls, and the final structure resembles the original structure. So in this diagram, we're going to see those four time periods. So the first step is the hematoma that's formed where the break is. So this is basically the clotted blood. There's swelling, pain, and inflammation, some of the main parts of the inflammatory pathway. The next is we start to see this kind of temporary fibrocartilaginous callus forming. The third is a bony callus forming. So you can see the beginning of the hard callus, and new trabeculae are starting to develop. So you can see in this image, we have the trabeculae that are located. And then finally, our last stage is the bone remodeling that occurs. And this is finally when the compact bone is starting to form the walls of the diaphysis in this case. Our next slide is showing us an example of some homeostatic imbalances. Osteomalacia is when bones are poorly mineralized. The osteoids produce, but the calcium salts are not adequately deposited, so it results in soft or weak bones. Rickets is basically the osteomalacia of children. So the term osteomalacia would be for adults. Rickets results in bowed legs because the bone ends are enlarged and abnormally long. So one of the causes for this could be a vitamin D deficiency, because remember, vitamin D is required for calcium absorption. So if that vitamin D is not present, the calcium from the digestive system is not going to be reabsorbed. One of the most common homeostatic imbalances for the skeletal system is osteoporosis, and it's a group of diseases in which bone resorption exceeds deposit. So here again, we see osteoclast activity, bone resorption exceeding osteoblast activity, which is bone deposition. The matrix remains normal, but the bone mass declines. So this is one of the reasons they do a bone density structure to see what degree of osteoporosis happens. For example, a weaker version of osteoporosis is called osteopenia, and it's very common in the spongy bone of the spine and the neck of the femur. So there could be vertebral or hip fractures that are common. So risk factors for osteoporosis are often aged postmenopausal women. It affects 30% of women aged 60 to 70 years and 70% by age 80. So estrogen definitely plays a role in bone density. Men are less prone to protection because of the effects of testosterone. But additional risk factors are insufficient exercise to stress the bones, a diet poor in calcium and protein, smoking, or genetics. This slide is going to show us what normal bone looks like and what osteoporotic bone looks like. As you can see here, it almost looks like there's been termites that have broken, that are kind of eating up the trabecula bone. And remember, it's most susceptible where there is spongy bone, so places like the vertebrae or in hip fractures. So treating osteoporosis involves some of the common things you might suspect, like calcium, vitamin D supplements, weight-bearing exercise, or even hormone replacement therapy. Can slow the bone loss but not reverse it. So we can see more normal bone here and extremely osteoporotic bone here. We can prevent osteoporosis by plenty of calcium in the diet, reduce consumption of carbonated beverages and alcohol, and the risk of those is they leach minerals from the bone, so it decreases the bone density. And of course, lots of weight-bearing exercise increases the bone mass above normal to buffer against age-related bone loss. The next one is called Paget's disease. And here's normal bone and Pagetic bone. And this is kind of like lots of increased bone density where it shouldn't be. It's excessive and haphazard bone deposition and resorption, called Pagetic bone. So there's a very high ratio of spongy to compact bone and reduced mineralization. It also occurs in the spine, pelvis, femur, and skull, and it rarely occurs before age 40. They really don't know exactly why it's caused, but it could possibly be viral. And the treatment is calcitonin and bisphosphonates. Our next slide shows the development of the bone. And this is an interesting image because the embryonic skeleton ossifies. So the fetal age is easily determined by x-rays or sonograms. Most long bones begin ossifying at 8 weeks, and the primary ossification centers are developed by week 12. After that is the secondary ossification center. So for some of these long bones, like the femur, for example, you can see there's no current primary ossification center, but there are secondary ossification centers here. So during birth to young adulthood, at birth, most long bones have ossified, except at the epiphysis. Epiphyseal plates persist through childhood and adolescence, but by age 25, all bones are completely ossified. So some age-related changes in the bone are shown here. Bone formation exceeds resorption in children and adolescents. In young adults, they're balanced. In adults, the bone resorption exceeds formation, so it kind of flips. Bone density changes over the lifetime and determined by genetics. And bone mass, mineralization, and healing, the healing ability decrease with age beginning in the 4th decade. So what I want to summarize is probably the most difficult part of this chapter is the hormonal control of bone remodeling. So I want us to consider the negative feedback pathway that occurs here based on calcium in the blood. So if this is our stimulus, this would be our response because it's a negative feedback pathway. So we would see PTH that's released by the parathyroid gland. And what you need to know is that's going to activate osteoclast activity, and the opposite would be calcitonin. So PTH is going to activate osteoclasts. And remember, these osteoclasts are like macrophages. And you should know that the osteoclasts are responsible for bone resorption. And the opposite of that would be that the thyroid gland would release calcitonin, and that is going to activate osteoblasts, which remember are the bone building cells. So it's responsible for bone deposition. So this is the important hormonal control that you should be aware of for this chapter, the hormonal control of bone remodeling.